Hello, I'm Dr. Israel Barken, the Medical Director of the Prostate Cancer Research and Education Foundation, and the topic this time on this video blog is focal therapy. It is very appropriate to talk about this topic because recently there was a hot debate about to do screening with PSA or not to do screening, and I feel that focal therapy and the approach of less aggressive treatments is the right answer to the people that want to stop doing screening. Because first we have to find the cancer, and then we have to find a way to modify our behavior to treat the patient appropriately. So let's go now and look at a drawing, a schema of how things are evolving. So screening leads to increased number of patients diagnosed. And we all know that since the PSA arrived, we have more and more patients being diagnosed. And what we have to remember that most patients being diagnosed, they don't have an aggressive cancer. So what's the problem? The problem is that we tended to do radical treatments for these patients that have a non-aggressive disease. And that causes some distress to the patient because one, they are subjected to side effects, quality of life issues like impotence or loss of control of urine. And on the other side, the real question is, do we really need such aggressive treatments? Will it really prolong the life or give us any better control of the disease by doing this very aggressive treatment? So we have to do behavior modification and stop with this approach, and we have to be looking for other approach that are less aggressive treatments. In that sense, my overall approach of minimum intervention and maximum surveillance is very relevant. And let me explain. The minimum intervention means that the patient will choose the less aggressive treatment that he feels comfortable from the point of view of quality of life issues. And we are all different in our approach, how much we want to take risk to live longer, but pay the price of not living well. So it's not only how many years we add to your life, but how much life we add to your years, or how much life, unfortunately, we detract from your years. That means you want years of quality of life. So less aggressive treatment, that brought to the question, well, wait a second, maybe we should not do anything and just leave the patient alone. We call it active surveillance because the patient still has to take active steps of mental attitude, diet, exercise, and get markers and imaging to try to define exactly in point of time, in the timeline, where is the cancer, how aggressive is the cancer. And we need those good tools so we could know when to bail out of this approach. By the way, the active surveillance approach, it's a lifestyle approach that has to be taken into consideration not only before a treatment, but also in between treatment and after treatment. That's something that we need to do all the time, especially trying to be on alert to know where is the cancer and how aggressive it is. And I must admit, and all of us must admit, that some patients are not built for active surveillance because it's too much anxiety for them to really do this. And the other point, they really don't like to have a needle stuck, to have a biopsy every year. The imaging is trying to replace the biopsies, but we are not there yet, but it's still a measure of reassurance trying to find out what's going on. So active surveillance, some of the patients on active surveillance have to bail out of this approach because they found out progression of disease. And then the question would be, what treatment shall they do? Should they move to radical treatments or should they move to focal therapy? So focal therapy is an alternative to people that don't feel comfortable with active surveillance. It's an alternative that becomes available once somebody failed the initial active surveillance. And it's available for those patients that either because of age or because of overall health or because of personal preference do not want the radical treatments. So let's talk a second about the focal therapies. The pioneer work about focal therapy was done with cryosurgery. Dr. Onig actually published a book in 2004. The name of it was Male Lumpectomy, trying to mimic the approach about breast, not removing all the breast, but removing only the cancer, the lump itself. And again, this approach is moving away from removing an organ, breast or prostate, to only the cancer itself, focal. The advantages are tremendous because then we avoid side effects, because when we remove the prostate, we are too close to an area where the nerves for the erection are passing, or too close to the place where the control mechanism for control of the urine is there. So we want to avoid coming close to those areas, and if we have the cancer inside the gland in a location where it could be treated, why not do it? So cryosurgery really demonstrated that people could have focal cryotherapy and they could have erection and have good control. And by the way, Dr. Doug Ban just published an article about his very favorable experience with doing focal therapy with cryo. Let's move to other modes of focal therapy, and maybe now is the time to mention to you that on our website we are very fortunate. We have a link to an article by the name Focal Therapy in the Management of Prostate Cancer, an Emerging Approach for Localized Prostate Cancer. This was published in Advances in Urology, volume 2012, article ID, and they give 6 digits of the article ID. Fortunately, the publisher of this magazine allows it to be used by the public. So when you get on our website, askdrbarkin.wordpress, wordpress.com, you could click and download that article to your computer and read it.